right. Hello, everyone, and welcome back to another subspecialty VMR. I love these Monday subspecialty VMRs. My name is Madalena Conti, and I'll be facilitating the session today. So today, the theme is focused on clinical reasoning. And we have two wonderful people here who are going to make this session happen. So our specialist discussant is Dr. Casey McQuade. And Casey, he's an academic hospitalist at the University of Pittsburgh Medical Center. He's the current director of graduate education for the UPMC Clinical Center for Medical Decision Making, among many other things. And he's also the co-creator of MedEd Pittsburgh. So Casey, so grateful to have you with us. And one question I was really curious about is if you could share with us a little bit about the origins behind MedEd Pittsburgh and just how you developed an interest in diagnostic reasoning.
Yeah, absolutely. I'll go in reverse order. My interest in diagnostic reasoning stems from the fact that, so I'm an internist by trade. My internal medicine clerkship was so hard. Like I had a really hard time getting it, honestly. So I spent a lot of time sitting around thinking, how do you actually diagnose people with stuff? And it more or less evolved from that. And I started getting more into the literature and had some good mentors. At MedEd PGH on Twitter stemmed from one of my friends approaching me and say, hey, you're interested in the clinical reasoning stuff. I'm interested in the Twitter stuff. Do you want to create a thread together on Twitter? And this was my buddy, Michael Simonson. And the rest is history. We decided to make this Twitter thing where we put out cases, which people seem to really enjoy.
That's awesome. Well, I'm definitely going to check it out more and try some of those cases. And I think we would all love to get to know you better outside of medicine too. So could you share, an interest or a hobby you have outside of medicine?
Yeah, absolutely. First of all, when you're in training and even when you're a doctor, don't let your hobbies go. They will help give you the strength you need for really hard training. I really like going on hikes, and being in Pennsylvania, there's a lot of wonderful hiking places. McConnell's Mill is amazing, not that far outside of Pittsburgh. It's just all very beautiful country, and I love being outside.
Yeah, totally agree. That's one of my big hobbies too. Awesome. And so our case presenter today is Dr. Raisa Silva, who is an internal medicine PGY3 at the University of Pittsburgh Medical Center. She did a postdoctoral research fellow at Massachusetts General Hospital before residency. And I see that she's currently doing research in inflammatory myositis and disparities in lupus, which seems so cool. So Raisa, thank you so much for presenting the case today. And I was wondering if you could share a little bit about the research you're doing right now.
Hey, I'm very excited to be here. Thank you guys for having me. Yes, absolutely. I'm very passionate about disparity. So the one with lupus is kind of the one closest to my heart. We are looking into adherence to the most common medications for lupus and the association of adherence and co-pays. In broad strokes, what we found is any copay above $10 decreases adherence very significantly, but there are more details into it. And the myositis end of part of the of research, another project, has a lot to do with online enrolling patients online for clinical studies and doing functional assessments at home, not needing to have patients come in for clinical trials and stuff like that.
Yeah, fascinating. Thank you for describing that for us. And we would also love to get to know you better outside of medicine. So what's one of your hobbies you have?
I love anything related to food. So cooking, eating, going to wineries. I love wine. And I love being outside too. Especially I love the ocean. So Pittsburgh's kind of tricky, but anything with water really. So the lakes also count.
That sounds wonderful. Me too. Okay, great. So we also have Marcella and Shema who will be helping with scribing and teaching points. Shema, could you unmute and introduce yourself?
Sure. Hi, I'm Shema. I'm currently a 50 medical student here in Berlin, in Germany. And just one side effect it's outside of medicine. Okay, it's a little bit medicine. I love sweets that are good for against the cough, but that's actually for children. And I always buy it from the drugstore. It looks like this. Yeah. But yeah, it smells like cherry, so that's why I always use it.
That's a great fun fact. Awesome. And Marcella, do you want to introduce yourself and share a hobby or a fun fact?
Yeah, sure. Thank you, Madalena. So my name is Marcela. I'm a doctor from Brazil, graduated last year. So I think my hobbies are mainly right now like reading, watching series. Like I know Rafa is also watching House of Dragon, so it's a very good series right now. I'm very much into it. And also cooking. Thank you.
Awesome. All right. So we've gotten the introduction, so I think we can start with the case. So if the scribe can, share your screen, and Raisa, we're ready for your case.
So we have a 37-year-old male. He's coming in. I met him at the clinic. So this is a clinical setting. He's coming in for right shoulder pain, bilateral elbow pain, and a recent history of left ankle pain as well. So a little, like briefly, the story is 2 weeks ago, this gentleman went to the ED with a history of a week of right shoulder pain that started very acutely. He woke up, noticed the shoulder was like very painful, very red and swollen. Couple days later, the left ankle, he woke up, it was also like painful, and he was like, I don't know. The way he described was, I don't know if I hurt my ankle because I was like getting out of bed every day without using my shoulders, from the pain he was on the shoulders, and did he hurt his own ankle as well? And at the time, he also mentioned dry cough and a little bit of malaise, just like not feeling right. I threw a lot of information there. So.
All right. So Casey, what's coming to your mind with this information that Raisa shared?
Oh my goodness. Well, first of all, as long as you guys can all hear me, we've gotten a lot of information from this guy, even without digging into like the past medical history. The time course is very interesting, and a lot of the descriptors that Raisa gave us, I think, are very important. So first of all, we have a young guy. This isn't somebody old who we would necessarily expect a lot of osteoarthritis in. So I'm going to be thinking about some sort of new process which has sprung up as opposed to an exacerbation of an old process. Now, Raisa, that's assuming you haven't given me a secret patient with Ehlers-Danlos that we're going to say has a lot of bad arthritis. I think probably not. We'll find out soon, I think. Okay, so in a young patient, I think thinking about those more acute things is going to be important. And you told me that the right shoulder happened, and then the elbow happened, and then the ankle happened. And I guess a quick question I would ask, did they go away, or did they all spring up sequentially and were present like at the same time?
The ankle went away. The ankle got better. And when I saw him, which was 2 weeks after the ED visit, he said first the right shoulder was terrible, and then it kind of went to the left shoulder. When he saw me, the left shoulder was a big trouble. The right shoulder still had some lingering pain, but the left shoulder was the main problem at the time. So it was first right and left. Yeah. The elbows kind of persisted.
Got it. So what we have is we have something which is acute in onset, and it's affecting multiple joints at once. So there has to be something that is more generalized going on in the person's body than something that could potentially just affect one joint. I am tempted to name this like a migratory arthritis almost, which is a big signposting thing for certain diseases because it has gone from joint to joint to joint seemingly. Broad categories of things I would be worried about are infectious etiologies. So a young guy with migratory arthritis, one of the big worry categories is a gonococcal arthritis. In a young guy in our area, unfortunately in Appalachia, there's a lot of intravenous drug use, so you could worry about endocarditis as well. And then, you know, I am kind of perhaps biased by the fact that Raisa is very much into the rheumatologic conditions. So I would put a host of rheumatologic conditions on there. Systemic lupus, you know, honestly, and I'm thinking, I said in our area too, depending on what type of activities he's into, you could think about Lyme disease as well as another reason to have multiple. So more or less infectious and rheumatologic categories are coming to mind. And I have a couple things in particular that are going to lead me to ask questions about, is he sexually active? Does he use protection when he's sexually active? What are his hobbies like? Does he like to hike like me? Does he remember any tick bites?
Amazing. I love how you kind of focused on the time course here, kind of the background that we got. Even we don't have past medical history, we have the age, and you kind of talked about how that influenced your differential. One question I had is, Raisa said that the patient also had a dry cough and malaise. Is that affecting your differential significantly at this point, or are you keeping that in the back of your mind? What are you doing with that information?
Oh, that's a great question, Madalena. So the cough, so the malaise is a very non-specific finding. I think perhaps that adds evidence to the idea that I think there's something more systemic biting at him at this point. Don't know yet. And the cough thing, so if it's either something infectious or, you know, something more systemic, infectious, rheumatologic, whatever the case is, could it be that something is affecting his lungs? I don't know. Maybe we'll find out he has seasonal allergies and it's true and unrelated. I would love some more data, and then we'll see if we can fit it together or if we can't.
Beautiful. All right, Raisa, I think we're ready for the next aliquot.
Yeah, just a little bit, because I don't know if it was on the history, like the pain he had during this like 3 weeks overall, like when he saw me, was so severe that like during these weeks he wasn't able to cook for himself. He said sometimes he had to like get one arm to like hold the other one and move because he couldn't move from the pain. So like he lost a little bit of weight, but he told it was mainly because he basically wasn't eating because he couldn't cook and do much at home with the arms the way they were. Past medical, nothing really. Healthy, like young guy. The only thing he mentioned was laryngitis that a doctor friend of him treated him like a few weeks back, like 3 or 4 weeks back, but that was the only thing. Meds, he was no meds. Family history, his mom had knee replacement for arthritis, but that was it. Family healthy overall. Social history, he works with gardening and landscaping. He does like to hike. He is sexually active, not consistently use protection, and lives by himself. What else? Doesn't smoke, doesn't use any illicit drugs, very socially, like drinks very rarely, and no allergies.
Yeah, Casey, does anything stand out to you here? And then, you know, getting into the exam, what are you most curious about?
Yeah, absolutely. Raisa, I love that you added in just how severely it's affecting his life. Sometimes asking patients that question in particular can give you a lot of clues. If a joint is that sore that you literally can't use it, the first thing on my mind is we need to rule out that any of these joints are not septic. Now, that is not to say that a joint that is that painful that it is debilitating, you know, the ankle or knee that you can't put weight on, the elbow or shoulder that you can't use anymore. It's not to say that the only thing that causes that is a septic joint, but I think that severity of illness makes me worried that, hey, I want this gentleman to get a tap sooner than later so that we can rule out septic arthritis, because that'll destroy the joint really quickly, and then he'll be debilitated for a very long time without some sort of replacement. The history of laryngitis intrigues me. It was phrased a little bit as a throwaway, but you never know what's involved. So thinking about our rheumatologic type conditions, you know, streptococcus could potentially give you a reactive type arthritis. I'm getting some like nods of encouragement from Raisa here for whatever that's worth. And there is a triad you can think about for some of the forms of reactive arthritis. Can't see, can't pee, can't climb a tree. That's perhaps usually a little bit more associated with sexually transmitted infection type reactive arthritis. But I would worry that this is post-streptococcal, or God forbid, someone had put in the chat that what was he treated with. If it wasn't treated like completely, could it now have turned into endocarditis? God forbid, and he has this seeding all over his body, don't know. But otherwise, I'm glad it's not just a case of Ehlers-Danlos. On exam, I'm going to be looking for just how tender and bad the joints are. I want to know if he is febrile. I want to know if he looks terrible, because if he looks terrible, my concern for a septic process has gone way through the roof. And then this is perhaps, I'll like listen to his lungs. You mentioned about the cough, Madalena, to see if there is some evidence, some rails perhaps, that it is affecting his lungs also. I mentioned already generally how they look gives you a lot of information. And then I want kind of our basic labs to see if he has a leukocytosis, if he looks like he's septic or not.
Great. I actually had one additional question before Raisa gave us the physical exam. So I was just reading back at the history Raisa gave us, and it seems like, you know, there are multiple joints affected, and then, you know, some joint, I think it was like the ankle or one shoulder was initially painful and then it resolved. Is that right, Raisa? So I'm just curious, that the fact that it seems like not all the joints are progressing, but some of them are getting better, and then what do you make of that?
Yeah, that's a good question. So a septic arthritis is unlikely to go away unless you do something about it. It should just get progressively worse and worse. If it's a more inflammatory autoimmune type process, or, and he is probably the wrong age for this, like a crystalline process, like a gout, that could come and go and come and go depending on the immune system's or the crystal's favorite joint du jour. So that perhaps throws me a little bit more in the inflammatory rheumatologic category. But again, like I think if you think about a septic joint, you should rule it out because it can be just that bad.
Great. Okay, Raisa, we're ready for the exam.
Okay, so exam temperature. So this was from the emergency room, and I now kind of tell the difference between when I saw him in the ED. In the ED, he was not febrile, he was 37.6. Heart rate was 95. Blood pressure was 135/84. And he was citing 99 on room air. Respiratory rate was 14. In the ED, they described as, you know, no acute distress. HE&T was normal, Perla, EOMI, moist mucous membranes, no oral ulcers, cardiovascular, regular rate and rhythm. Pulmonary was also normal, clear auscultation bilaterally. Abdomen was soft. Neuro was completely normal. In extremities, so in the ED, and I think the exam is probably similar to when I saw him, but he had significant swelling in both shoulders. When I saw him, it was left more than right, both elbows and wrists as well. Shoulders were like erythematous and very painful to the touch. He was kind of holding one arm with the other one, like trying to balance it out. And he also had sinus tenovitis, like in both wrists, like bilaterally, and the elbows were also tender. When I saw him, the ankle was completely normal, but in the ED, they described left ankle swelling as well.
Wow. So that's literally, it's like everything, more or less. Not his like spine. So this is probably actually worth mentioning. Not his spine.
Nope, no back pain, no tenderness, spine was good.
Yeah, interesting. Okay. Yeah, I'm just gonna dive in if that's okay.
Yeah, please do. Yeah.
Yeah, okay. He is afebrile, you know, he's 37.6, so it makes you wonder, is he coming down from a fever? He would probably have sweats if that were the case, if he had come down from an actual fever, I would presume. It's like literally all of the joints. I'm exaggerating for the sake of teaching, but this also perhaps points me away from like a septic arthritis, because if you have involved almost every single large joint in a person's body and you're not dying of overwhelming sepsis because you have MRSA bacteremia or streptococcal bacteremia ongoing, I just don't think it would be that. I think you would look way sicker. So I'm going way more heavily into the rheumatologic category and kind of perhaps reactive arthritis type category. Someone, I should draw attention to the fact that Dale Cobran put about acute sarcoid or other granulomatous disease as well in the presentation. Definitely for something like migratory arthritis, they had put that in the chat. I think that's a great idea. Paul is mentioning about the SI joints. I don't know, that was kind of wrapped in my mind as like testing his spine and stuff, but you could see if it involved his SI joints. Doing the Faber maneuver, which is abduction and external rotation, essentially making them kind of cross their legs in bed, can help with that. It stresses the SI joint, also the hip joint, so you can see if there's pathology in there. But I'm definitely going more towards the reactive or rheumatologic, or like, you know, I wouldn't take gonococcal arthritis off of the table either here. I would still tap it and send it for culture just in case. I would still obtain blood cultures just in case. I would send testing for chlamydia and gonorrhea as well. And then I would start testing him for particular, and like whenever you tap the joint, you make sure there's no crystals and such. And then I would start sending testing for different rheumatologic diseases. So like we already have in the teaching points, lupus, rheumatic fever, which would go along with this like post-streptococcal disease, sarcoid. Perhaps we can talk about the testing for rheumatologic diseases once we get to the labs and stuff. So I'll save that, some little pearls for that a little later.
Yeah, I thought that was an amazing analysis, and I was going to ask a little bit about how you would work this up, but you totally just covered that. One kind of like practical question I had is, you know, Raisa described that there's a lot of different joints that are swollen, the shoulders, bilaterally, the elbows, the wrists. And so you mentioned, you know, tapping it to see, you know, testing for crystals, infections. When you have multiple joints, like which one do you tap? And all of them, you know, how do you do that?
Yeah, that's a good question. You tap the worst one, the one with the biggest diffusion. Now, in my experience, and I'll come right out and say that I, unfortunately, do not tap people's joints. It's never a skill that I've learned, or at least yet have learned. Knees are great because there's a great big joint space. Which did you think was actually the biggest, Raisa? Sometimes you can get fluid out of wrists if they're bad enough. Sometimes ankles, those like, a wrist is actually secretly a bunch of different joints all floating in the same space. But what did you think was actually biggest? Were there big effusions that you could actually stick a needle in, Raisa?
There were. The only thing when we saw him in clinic, I think there had been like more than 2 weeks for sure, then those effusions were there. So it was, that had some component of maybe like chronic synovitis kind of thing, like more like subacute. So they weren't, you know, just like very acute picture. But I actually thought the elbows were very striking, maybe because we don't see elbows that commonly, at least I don't, you know, it's not the most common joint to be swollen like that, but I thought the elbows were very striking.
Okay. Yeah, maybe you could go for that. I guess some of the tricks that's coming to mind is there's also, in a lot of these joints, there are also associated burses. So you could try to ask the question, well, gee whiz, is this actually a bursitis that you're dealing with? And like if it's, so my picture is very small on here. I don't know if you'll actually be able to see me gesticulating, but I've seen someone who has a gigantus bursitis on their elbow. It was actually just contact because they get chronic, they get hemodialysis 3 times a week, and the way they sit in the chair, they put a lot of pressure on their elbow, and so they had just accumulated a lot of fluid over time. But that's it's kind of irrelevant. If it's an inflamed bursa, you still want to know if it's infected, if there's crystals, so on and so forth. That perhaps just makes it a little bit easier depending on where it is. So I would involve either rheumatology or orthopedics, whoever is handy and willing to help me out with tapping a joint, and pick the biggest and easiest one.
Awesome. Okay, I think we're ready for the next aliquot.
Okay, because I saw him in clinic, the labs I had were from the ED. So we have Bible count of 12.9. Let's see, hemoglobin of 12.6. Platelets 350. Sodium BMP was overall normal. Sodium 139. Potassium 3.9. BUN 10. Creatinine 0.7. LFTs were normal. Billy was normal. All the electrolytes were okay. I will give you a few other things. ESR was 107. CRP was 27.9. They did do Lyme antibodies because he mentioned one tick bite, but the tick was only attached for 1 hour, but they still did, and it was negative. They did do blood cultures, and the patient was discharged from the ED without the results. And we saw the results when he was, in clinic. They came back 2 out of 4 bottles positive for staph epidermidis. And what else? COVID was negative. And no imaging.
Yeah, cool. The staph epidermidis. So staph epidermidis is a great commensal organism. It lives on everybody's skin. 2 out of 4 that has been sat on, and he hasn't gotten sicker and he hasn't started fevering. I'm less inclined to definitely say that is, let me phrase it backwards. I'm pretty sure that that's actually a contaminant as opposed to a true infective organism. That's probably the clearest way to say this. Yeah, so I think that's a contaminant. His ESR is 107, which is tremendous. So ESR over 100, I want you guys to keep a couple of things in mind. Thing number 1, endocarditis. Thing number 2, multiple myeloma. Thing number 3, vasculitis and other rheumatologic conditions. I don't necessarily think he has a vasculitis at this point because we're talking about joints and not about skin changes, petechiae, headaches, vagina, so on and so forth. Yeah, I think this guy definitely has some sort of rheumatologic condition or inflammatory condition at this point. Less concerned about a completely unabated infectious etiology. I'm guessing, Raisa, you saw him in room clinic as opposed to in primary care clinic. Am I getting warmer?
You got it, yeah.
Okay, that's probably completely unfair. I'm just picking on Raisa because she's one of our amazing stellar residents at the University of Pittsburgh. Yeah, it's interesting. So I think, yeah, an unabated infection. I don't think infection is not on the table at this point. So I would start going down and try to rule out some rheumatologic conditions. We have some data now, like I was talking about before. His lungs, I didn't mention this before, his lungs were normal. He has a normal SpO2. I'm wondering if the cough is just completely unrelated unless it has gotten worse or he is now dysmic or something strange. It's thankfully not something that is eating at his creatinine, but a normal creatinine doesn't necessarily tell you that there's not a renally active process going on. In a patient that you're working up for a rheumatologic condition, I would also get a urinalysis and look at microscopy just to make sure that they do not have a bunch of red blood cells, a bunch of unexplainable white blood cells. They do not have red cell casts, dysmorphic red blood cells, or like white blood cell casts. Just want to make sure this guy doesn't have, I want to make sure this guy doesn't actually have like a glomerulonephritis that's actually going on as well. I would be I'll listen to whatever question you have, Madalena. Marcelo is asking for problem representation, which I'm all about. I've just gotten so carried away because I love this case, but we can go whatever direction you want, Madalena.
Oh yeah, no, I would love to hear how you're framing the problem. Yeah, let's start there.
Yeah. So I would say a previously healthy 37-year-old male with recent laryngitis who's presenting with the subacute onset of a migratory arthritis, who is found to have extremely elevated inflammatory markers, and so far a negative workup for infection, including unconvincing blood cultures and negative Lyme serologies.
Beautiful problem representation. One question I had, so you walked through your thought process very clearly about, thinking infection is a little bit less likely, more in the bucket of rheumatologic causes. I'm curious if, which specific rheumatologic conditions are coming to mind, or what tests would you be thinking of sending to narrow that list?
Yeah, great question. I still really like the idea of reactive arthritis given the recent laryngitis. That's probably, I don't know. That's probably just me hoping for an interesting diagnosis because this is an interesting case. But I do wonder if that was streptococcal in some way. You could think about a lot of the things that we already have written down here. Like what is mentioned is lupus. It's perhaps more common in women than men, but can still happen. I would still want to rule out a gouty arthritis in him. Someone, HIV was not tested. That is good. And I don't think you mentioned, Raisa, that the GC and chlamydia. I didn't think I heard about that.
They were negative. They also did in the ED.
Okay. I just missed it then. Sorry about that, guys.
No, I forgot to say.
Oh, that's fine.
Forgot. But
so I would start. I would almost be interested in what happens, hearing from Raisa, what happens in rheum clinic. So the classic teaching on testing for rheumatologic conditions is you start out by sending some of the basic testing. Let me talk broadly first. So like things that are mutually exclusive are like rheumatoid factor, because that is specific antibodies to the FC region of an antibody. ANA, which are antinuclear antibodies, and then ANCAs, which are anti-neutrophil cytoplasmic antibodies. A lot of you have probably seen testing where they send an ANA, a double-stranded DNA, Rowe, Law, Smith. They're sending a whole bunch of anti-nuclear antibodies at the same time. And if they had gotten a negative ANA, all those other anti-nuclear antibodies are also going to come back negative because they're also nuclear antibodies. They're just specific types of them. So the most parsimonious way you could do this would perhaps be to send rheumatoid factor, like more or less start with screening things, and like rheumatoid factor and ANA. I don't necessarily think ANCA does this stuff, but somebody correct me if that is wrong. And we already did the gonococcal stuff. We did the Lyme stuff. Oh, geez. If you could think about sarcoid and the cough and get a chest x-ray, which we haven't broached yet, to see if he has a bunch of lymphadenopathy. I would base that on whether or not the cough is still there and how bothersome it is. This would kind of be weird though, for it to present as just arthritis, but we're open to weird.
The cough was not present anymore when I saw him, by the way, had resolved.
Cool.
All right, that was a fantastic walkthrough of what test to send and kind of the order in which to go about that. So we'll jump to the next aliquot.
Melina, do you want me to say like kind of what we did on the visit?
Yeah. Yeah, that would be great.
Awesome. So the first thing we did was I actually called the lab just to make sure about the blood cultures, because even though, you know, he wasn't looking toxemic or anything, but I called and they said that the 2 positive blood cultures are collected, let's say at 6 p.m. or something. And so those were the 2 positives, and the other 2 sets that were collected like later were negative. So they're like contamination from the first draw, as Casey said. And so the thought was, Casey, you nailed everything you've been saying so far. It was, you know, this is very acute, very debilitating, very inflammatory arthritis in like a young guy without any past medical. So first, it was in room clinic. The attending tried to tap the left elbow, but we ultrasounded first. And on ultrasound, it looked, there wasn't a small effusion, but it looked more like chronic synovitis at this point. So he couldn't get anything out. He couldn't get like any fluid out, unfortunately. So it was, you know, dry tap. And then the patient didn't want to try any other joints because he was in so much pain. So we repeated ESR CRP that now having the results, they were 16 and 3.8 from those numbers before. We got RF and anti-CCP for him based on the idea that he had kind of symmetric, let's say, wrist and elbow involvement. They're all negative. And we repeated Lyme antibodies, chlamydia, gono, and UA, and all those were negative/normal. And we started a prednisone taper, the favorite, you know, rheumatological medication, with the thought that either this is reactive arthritis or like a peripheral type of spondyloarthropathy. Even though he doesn't have the back involvement, there's the peripheral subtype. So those are the 2 kind of main thoughts. And again, you nailed it, Casey. Like what we thought about the cough was, because the most typical for reactive arthritis is GU and GI, but is this some sort of like post-trap or some other sort of like viral something that he had with the cough, and now he's having reactive arthritis because of that. And he actually came back to room clinic 4 weeks after I saw him, and he was like 90% better. Like joints were functional, he was back to work, he was feeling great. So basically almost everything resolved with the 4 weeks of steroids. And the attending thought was mainly now we have to watch him over time. Like if he never develops anything else again, this was probably like reactive arthritis. If he is to have something in the future, then it would probably be you know, one of the seronegative but not reactive, like peripheral spondylar arthropathy.
Yeah, that's you don't get credit for saying after the fact what you were thinking, but that was also a part of me like being, so reactive arthritis, I'm pretty sure goes away. So that would be a lot better for him than to say he's 37 and he's, you know, that's young to get like rheumatoid arthritis or something that's going to deform his hands over time. I just saw a poor lady the other day who has like all the swan neck deformities and such. So you fixed him. Excellent work, Raisa. I'm glad he's doing better. But yeah, I put in the chat scary because it's like, oh gosh, you get pharyngitis and then you wake up and your joints like all don't work anymore. the human body and illness is just amazing what it's capable of accomplishing, I guess.
Yeah, and I thought this case was interesting because, as you know, let me put it that way, that the joints were as impressive as the ESR. So it was very, very impressive, you know, the swelling, like he couldn't do basically anything. He was out of work for like 3 weeks by the time I saw him, because of pain and swelling, and he was clearly not someone that like complains or goes to the doctor. He didn't doctor, and he still like went and followed up and everything, kind of showing like how much, you know, his life was affected by all this.
Here, I'm going to test something real quick. If I Google, I want to make a really quick clinical reasoning teaching point, if that's okay, guys. Cool.
Definitely okay.
So there's, where I went to medical school, there's a dermatologist by the name of Jim Treat, who is excellent and taught all of us medical students how to like name rashes. And one of his big points, which I took forward to a lot of clinical medicine, was if you can correctly name the rash, in this case, if you can correctly name the problem, sometimes you can Google it and get yourself a really good framework or a really good differential diagnosis. So in this case, even if you're like, oh my gosh, this guy has like a gazillion joints, like what is this? If you make the step and say, it's moving around, so it's migratory arthritis, or even if you get close enough to say polyarticular arthritis, you can Google, and like at least the way I'm coming up here for migratory arthritis, there's an American, what is it? American Family Physician article, which gives you a great migratory arthritis differential, which says gonococcal rheumatic fever, which is along the lines of the post-strep, like we were talking about. Someone put about Jones criteria in the chat, which is a great point. I wasn't even, my brain wasn't connecting that. It says lupus, Lyme. So like, if you can rename your problem sufficiently, sometimes that can help you a lot if you're stuck, either by Googling or going to a reference or something. So do rename your problem lists as you go, because that can help you out in a pinch.
Yeah, I think that's a fantastic teaching point. Actually, Casey, I had a question about how does the patient's improvement on prednisone affect how you're thinking about the final diagnosis? I think a lot of people have put in the chat that prednisone can improve a lot of different types of conditions. So how do you think about that?
Yeah, that is a great question. So the cognitive bias that is outcome bias. I have a good outcome. Therefore, what I was thinking was right from the beginning, right? It's a trap. Prednisone does make a lot of things better. It can make the inflammation from an infection better temporarily before they get overwhelming sepsis. It does tell me that it's probably not some sort of underlying looming infection that we haven't diagnosed, because that would go out of control. It tells me that there was some sort of inflammation deep set in the joints that needed to be treated. But other than that, the physiology of we've treated some sort of inflammatory something, including, a very weird polyarticular form of gout or whatever. It doesn't tell us what the diagnosis is. It just tells us that we've hit a hammer with a nail successfully. Now, like what Raisa said is actually very important. What's the natural history for this guy? Nowadays, at least the way hospital medicine works in the United States, is you fix the acute problem and you send them out in the hospital. What they used to do like 30, 40 years ago is they would keep people in the hospital to convalesce for a long time. And so people got used to seeing in the hospital these big, long courses of diseases of like, I don't know, PJP, endocarditis, like whatever the case is. You'd see the whole course as one doctor taking care of the same patient. Now the natural history is really disjointed in all of our brains, and you only get that follow-up if, like Raisa's attending, you follow this patient again like every 6 months to see how he's doing. If it comes back, then there's some other underlying inflammatory or autoimmune, disease that's going on that maybe needs additional workup and treatment. If it goes away and it stays away, maybe it's a one-off mistaken antigen, like reactive to the streptococcus or viral, whatever, that he had before. So that's a very long answer to say it doesn't tell you much other than your nail has hit a hammer instead of a screw, and you just got to follow the guy and see what happens.
Yeah, I think that's a really, really important reflection. So we are, before we jump to teaching points, Raisa, I just wanted to really thank you so much for presenting such an interesting case and kind of unraveling it like a story. It was just really, really well presented. So thank you for preparing it. And Casey, I wanted to see if you had any last reflections before we jump to teaching points.
Yeah, I'll make one really quick point. Rheumatologic conditions, because there are a bunch of them and there's like a bunch of lab tests to order and things, can be very daunting for people because there's a lot of information to sift through. They're still even daunting for me, when you're presenting and it's like joints, it's like, oh gosh, this isn't, I don't know what this is going to end up being. But just stick with it, compare different things as you read, and eventually you'll start to get a sense of how to categorize them in your brain. I'm certain from the times I've talked with Robbie and Raisa, they would probably agree with that as well.
Fantastic. And Raisa, I actually wanted to, because you mentioned your interest in rheum, and I think you had talked about the consideration of, serology negative arthropathies. Could you, share with us what you know about that? I think I would benefit from some teaching on that.
Yeah, no, I don't know much, but the group of like the spondyloarthropathies, like they're called like seronegative spondyloarthropathies, like in general, like those four like main ones that we think about, like reactive arthritis, the IBD related ankylosing spondylitis, which I think is maybe the more famous one, and the one associated with like psoriatic arthritis, exactly, the mnemonic. So they're considered seronegative because they're always like RF negative, and they're usually like negative for everything else pretty much. So they're more like clinical diagnosis. And one thing that I think I will highlight, because someone mentioned on the chat, is that because every time we think about, at least I used to think like that, I think most of us think about like spondyloarthropathies, we think about back pain, like lower back pain, that like inflammatory back pain with stiffness and stuff. And there's the subtype of like peripheral spondy. So that is like very subdiagnosed, because we always like, we tend to have difficulty to think of like, elbows and like shoulders and wrists as seronegative spondyloarthropathies, just because the most common thing is like back pain. But it's definitely a subtype where back is like completely normal, and they have all this like lower joints, as Casey mentioned, like affected, and like very inflammatory, very debilitating pain and arthritis.
Masterclass teaching. Thank you, Raisa. Well, thank you, Raisa and Casey, for all of the clinical reasoning pearls and teaching you gave. I think we all feel more confident about the approach to joint pain. At least I definitely do. So we will pass the mic to Shema now to go over some teaching points.
Hello, everyone. Thank you so much for this amazing case, and also for the amazing discussion. I will try to go through some quick teaching points. So we had as a chief complaint migratory polyarthritis, and we learned to think of 3 buckets, namely infectious, especially the STIs if we have a young patient, but also be aware of IV drug abuse, which can cause endocarditis, and also of Lyme's. And then in the rheumatological bucket, think of SLE, but also the spondyloarthropathies and also sarcoid. And then by Googling, I also found a paraneoplastic one, which is carcinomatous polyarthritis. And if you have an impaired range of motion of a joint, always rule out septic arthritis. So usually we perform an arthrocentesis. And then for reactive arthritis, as we have this great mnemonic, can see, can peek, can climb a tree. Be aware that we think most commonly we have GU or GI causes, but also post-strep is possible. So I wrote down I was always considering post-strep more of rheumatic fever, but there's also this post-strep reactive arthritis, which is basically when the Jones criteria don't fit. And then we also learn about the basic workup of polyarthritis. So we perform an alphacentesis, do blood culture, test for STIs, and then there's this rheumatological panel. And then we learned a 3-step approach for an ESR above 100. So think of endocarditis, multiple myeloma, and vasculitis, and other rheumatological disorders. And also, if you have a normal creatinine, be aware that you can't rule out an impaired renal function. So always do urine analysis to see whether we have hematuria, like indicative for glomerulonephritis. And then the pearl with the steroids. So we know steroids make a lot of better, so usually inflammatory states, but also the inflammation of an infection can get better before this patient gets septic. And then Dr. Raisa Silva also told us about something about the seronegative arthropathy. So we have the reactive arthritis, the IBD-related psoriasis arthritis, and also this peripheral ones. And also think what seronegative basically means. So we learned is like rheumatoid factor is negative in these cases. So thank you so much for listening, and hope to see you all again soon. And thanks for the discussion.
Amazing. Love those teaching points, Shema. Thank you so much for summarizing them. And thank you to Casey and Raisa again for the wonderful teaching and for taking the time to be here. And thanks for everyone for tuning in. We'll see you guys next time.
Thanks for having us.